So today we are just going to have a look at, when there are several tests available, then how do we combine them? How do we need to combine them, and so on. Just scratching the surface, but anyway, just getting a few concepts across. So like we said, there are two positives, and all our attempts in diagnosis is trying to increase the value of the number of the true positives and the true negatives. We want to minimize the false positives and the false negatives. So all our efforts are trying to get a better test, to combine tests and so on, are just to increase the true positives and the true negatives. But it's like we saw earlier, the true positive rate or sensitivity and the false positive rate, which is 1 minus specificity, is a seesaw. One goes up, the other one goes down. So when there are two tests like this, isotope scan, CT scan, we got ROC curves. How do we decide which is a better test? Which do you think is a better test? Okay, so the greater the area under the curve, the better the test it is. So CT scan is better. But if you want to combine the two, does it work? Do we gain much more in doing that, and so on? So these are issues these are all complex, but at least to introduce you to some of these concepts. So the objective of today's session is to understand the use of multiple tests, and basically we can do tests in series or tests in parallel. So in series mean one after the other, and we can have some sort of a decision framework ahead of time. So when we do it in series, we can say that, how are we going to say? Are we going to take a positive in all, or that we have to define. If you're doing in tests in parallel, again we have to say how we're going to react to these tests. So basically, our strategy could be serial testing or parallel testing, and the sequence of events would be you do A, and then that is positive, you want to do B, that is positive, then you do C, and so on. And if it is negative, you ignore them. That's the usual way of doing serial testing. So the consequences of this would be to decrease sensitivity, but you're increasing specificity. So usually when you're dealing with dangerous treatments, like chemotherapy, radiation therapy, surgery, you like to increase specificity, and we don't mind losing a bit of sensitivity. So it is a trade-off always. Like most things in life, there is a trade-off. So serial testing, for example, you have a history, examination, inspection, like in gynae, you do a speculum examination, look at the cervix, you might put acetic acid, then you do a pap smear, then you do HPV testing, then you do colposcopy, and so on. Then you finally do a biopsy or whatever. And then you take her up for surgery. So it's trying to be as specific as possible. The other strategy is to do parallel testing, where you do all the tests at one time, and you count if any one is positive, you might. So one way of doing it is you do A positive, if it is negative, then you do B, and if that is positive, fine. If B is negative, then you do C. So this is one way of doing it. Or you just give all three tests together, and you just take, if any one is positive, you treat. And for something like tuberculosis, or I'm sure you can think of examples in your own field. So this strategy would increase sensitivity, but you're going to lose on specificity. So again, which strategy you're going to use will depend on the disease condition and also the treatments that are available. So multiple tests, so it's parallel testing all at once, and a positive result of any test is considered evidence for disease. Rapid assessment is needed. Example, hospitalized or emergency patients, you would do the whole battery at one go. And it's useful when you need a very sensitive strategy, and it is not effective. Net effect is a more sensitive diagnostic strategy, but you lose on specificity. Serial testing is consecutive testing, and the decision to order the next test in series is based on the results of the previous test. So all tests must give a positive result in order for diagnosis to be made. This maximizes specificity and predictive values, but lowers sensitivity and negative predictive value. So serial testing, doing the test sequentially instead of together with the same decision rule. So we could have one decision rule that you will treat only if all tests are positive, but like I said, you don't want to do all tests at once, but we do it sequentially. And this is a cost saving measure. So this strategy increases specificity above that of any of the individual tests, but marks your sensitivity down below that of any of them singly. So the serial test, because it is increasing in specificity, is good to rule in disease such as cancer. Like I said, this parallel testing, when you give all at once, or if to save costs again, the second test is done only on those who are negative by the first test. Okay. So this is a modified or parallel testing where you do test A if it's positive, negative, and then you do test B on the negatives. Then you say positive, negative, and you say if either A or B is positive, you consider disease is present. Okay, so let's do an example, and I'll give you some numbers and you can see if you can work it out. I'm sure there'll be some statistical formula to give the answer, but I've done it the hard way of just using some number as a sort of a simulation. Yes?
So if we are doing tests in series, it will decrease sensitivity. So how is it possible? So because after one test we are testing the other, only the first test is negative, we are doing the second test. So
Positive. Positive.
Sorry, only the first test is positive, we are doing the second test. Then how will the sensitivity be?
It increases specificity, decreases sensitivity, because all tests have, your rule is, the decision rule is that all tests have to be positive. Okay, so all tests have to be positive means it's you're going to get less numbers, no? Suppose there are 100 positive in the first test. When you do the second test, out of the 100, you may only 90 may be positive. So you already have lost 10. Then you do the third test, 90 becomes 70. So finally only 70 are positive on all three.
Okay, sensitivity is for all three combined. I thought it will decrease the individual.
Sir, if you take one test positive, then you are increasing sensitivity.
Yes, that's parallel testing. See, that is parallel testing. Okay, go back to the serial testing is one, you do first test, if it's positive you do the second test, if it is positive you do the third test, and so on. So you get less and less and less as we keep going. So you are picking up less. That means sensitivity is less. Here you are doing all that and you are taking any positive. Okay, so here you get 100. Then after these negatives you get a few more. So 100 becomes 110. Then 110 becomes 130. So you are picking up more and more. So that increases sensitivity.
Sir, here in the parallel model, only for A negative you do the B, but it's not like that. You do everything together.
Any one of them is
That is what I said. No, if it's either you can do all together, or to cut cost, use a modified parallel where you do it only on the negatives.
So it will increase the number at least.
Serial also is, this is like a modified, because you can do all the tests at one time. See, it is not the question of doing all the tests at one time. You can do, if you want to save time, it depends on time. If time is very crucial, you will do all the tests at one time. Whether you use a serial strategy or a parallel strategy, you can give all the tests. But you decide beforehand, I will consider disease only if all are positive, or I will consider disease if any one is positive. So that is the decision rule. But whether you give all tests at one time or you give it sequentially is a balance between cost and time. Time is also money, but if you have enough time, then do it sequentially. If you don't have time, do it all together. Okay, so that's basically it. So that's either two strategies, parallel, serial, and two ways of doing it, all together or sequentially. Okay, so prevalence of cervical intraepithelial neoplasia is 2%. Pap smear sensitivity is 60%, specificity is 95%. HPV test is sensitive 90%, specificity is 90%. So what do we do now? So the thing is, you got a choice. You go to the cafeteria, there are so many items there. Do you want a buffet where you eat? When you go to the buffet, it's always confusing. You want to pile everything on your plate, or you want to just choose a few? Now what do you want to do? You got so many tests available. Okay, so this is not cancer, it is pre-cancer. So how do we approach it? I mean, you can do it, it's a simulation exercise. So what do you say? Should we do it? What strategy are we going to use? So it is in the patient comes to the clinic is different, but when you go into the when you're doing large numbers, then we have to be careful. Okay, let's we check each section by section. This section, what do you want to do? Serial testing. Okay, what about those at the back? Anybody? Any other? Okay, middle section. Okay, you want to do standalone? Okay, so what are the options? And this section? Serial. Okay, so there are a whole lot of options here. We can do just pap smear. We can do just HPV. We can do pap smear followed by HPV, serial testing. Or we can do HPV test followed by pap smear, again serial testing. Or we can do parallel. That means you do both what we call co-testing. Give both at the same time, and you say if anyone is positive, you can do it. Or you do pap smear first, then the negatives you do HPV. Or you do HPV first, the negatives you do pap smear. So a whole lot of strategy, combination. How do we decide what to do? As a clinician, how are we going to do? Or as a policy maker, how are we going to decide? Okay, so let's for a simulation exercise. Okay, you're supposed to do screening on 100,000 population, 100,000 women in this area, in one district or one block. So let's try standalone testing first. Standalone means just one test. If you do pap smear, sensitivity is given as 60%, specificity is 95%. You've got 100,000 women. Prevalence is 2%, so you got 2,000 here. Okay. 60% of 2,000 is 1,200. You're going to pick up 1,200, right? 98,000, specificity is 95%. You'll pick up 93,100 correctly identified as normal. These are false positives, false negatives. Okay. Whereas if you do only HPV, 90% again same 2,000 because the prevalence is constant. That is the truth. We are saying that is 90%. You want to pick up 1,800. You're going to miss 200. The false positive goes up here because your specificity is only 90. So 9,800 are going to be false positives. So which strategy do you like? Who wanted pap smear alone? Who wanted only pap smear? Okay, any reason? Positive predictive value is high. So 1,200 divided by 6,100. So quite between the two, positive predictive value is more. The false positives are less. Who wanted HPV? Somebody wanted HPV? Okay, what's your reason? You are picking up more. Okay, so sensitivity. So how do we convince our health minister? So the problem is now, what do you do with the result? See, you do a test result, but you have to always think of what are you going to do next? So when we did screening, we said, no, the workup is important. So normally, the traditional teaching is, if one of the screening tests is positive, then you have to do colposcopy, biopsy, and so on. Okay, confirm. So that means we have to do double the number of colposcopies. Who's going to sit and do all the colposcopies? Do we have enough colposcopes? we have enough gynecologists to do it, that's a problem. See, now, for example, Tamil Nadu is doing it. They are doing VIA screening. All the positives have to go to the district hospital for colposcopy and biopsy. So are they able to manage the load? So these are the issues that the policy makers sitting in Chennai will have to decide. So this is one strategy. Again, either pap smear alone. So pap smear has been the traditional way of screening for cervical precancer all over the Western world, and they said that it's fantastic because the cervical precancer is coming down, the cancer is coming down, etc., etc., etc. But in India, we don't have any screening, still it's coming down. Same thing happened with TB. Even without the vaccine, BCG vaccine, the incidence of TB is coming down, and that's because improved socioeconomic conditions, improved nutrition, and so on. So there may be multiple reasons why incidence may come down, but anyway, soon the industry will come in. They have found a new HPV DNA test, and HPV RNA test, and protein markers are there and all that. So then the industry starts pushing, and now slowly the world has changed. Everybody is saying HPV, and saying pap smear is useless. Why? They're only basing it on sensitivity, saying you're picking up more. Okay. But also, we can't forget that the false positives are much more with the HPV. So this is a problem. If you're going to, or are we going to treat everybody? So the another strategy is to treat everybody. Don't do any colposcopy, don't do biopsy, just treat everybody. Sorry. Yeah. If you're treating everybody, then you're going to, all these are unnecessarily treated. 9,800 women are given treatment, either cryotherapy or thermocoagulation or excision, when there's nothing there. So this is the problem with the diagnostic test. No, you can't, it's not only the number of cases you pick up, but also what are you going to do with these false positives. Okay, let's look at the other strategy, those who wanted series. Okay, PAP on 100,000 followed by HPV on 6,100. Are you following? You are doing pap smear on 100,000 women. So this is how it goes. Are you following this? Go back to the next one, previous one. Pap smear. So these you are doing it on these 6,100 women who are positive, right? You are doing serial testing, correct? You are forgetting these are, you have said, are all negative. So you take these 6,100. Right? 6,100, you do there are 1,200 positives there. You do the HPV now, 90% sensitive, you will pick up 1,080. So you are sacrificing sensitivity. From 1,200, you are willing to let go of 120. But you have now brought this down from 6, what was the number earlier? 4,900 has now become 490. You have cut it by 10%, 10%, yeah, 110. Made it 110, yeah, 90%. So now you have to do colposcopy on 1,570, not on 6,100.
Second one, couldn't understand. PAP and HPV both negative.
Yeah.
But the 6,100 all are positive for PAP.
PAP. Yeah, all are positive for PAP. All are positive for PAP. This is PAP. Yeah, this is PAP positive. PAP, sorry. This is sorry. Right. PAP positive. PAP positive. All are PAP positive. Because we have taken only the positives. So yeah, this is a mistake. I need not have put this here, but what I left out the PAP positive. Yeah. Okay, so if this is the advantage of serial testing. You are losing a little bit on sensitivity, but you are gaining a lot on specificity. So now, this is the third option now. The other option is, you do HPV on 100,000, followed by PAP on 11,600, right? 11,600, all are PAP, HPV positive, sorry, HPV positive. Take these 11,600, now you do pap smear. And you have, with 90% sensitivity, 60% sensitivity, and 95% specificity, you will get this table. Any comments? Hmm?
So what is being missed by HPV PAP will pick up how that
Sir, sorry?
What is being missed by HPV?
Hmm.
PAP will follow to that importance. Because HPV is negative or positive, then in PAP.
No, we are doing serial testing here. So we are doing serial testing. Go back to you have to take all the slides together. So this is the standalone I gave you, PAP and HPV separate. If you do PAP first and then you do HPV on these positives, that is serial testing. With the decision rule that you have to have all positive. Or you do HPV first, right? And on the 11,600 you do PAP. Okay. So any comments?
Even A and B and B and A.
Okay, so what you see here is whichever you do first, mathematically, you pick up the same number, 1080, 1080. That's interesting, isn't it? So when you do serial testing, it doesn't matter. What does it? Does it matter? Okay, so the both ways the number picked up is the same, the number positive is the same, so the number of colposcopies are the same. So what is different? Okay, so whether you want to do HPV on 100,000 or whether you want to do PAP on 100,000 is the question. Okay.
What about the lowest false negative?
Sorry?
What about the cases with these false negatives?
Here, these 490. Sorry, these 720. Yeah, you're losing. Out of the 1,200, you're picking up only 50%. Out of the 1,000, you have lost. See, this way, we have lost almost 920. Yeah. We are picking up only little more than 50%.
Also lost false negative in the PAP. Before this, because we didn't account for it. Before this, if you go on standalone, the PAP negative doesn't get picked up in the serial. The false, the other one, the C.
This one?
Yeah, because you've directly only gone ahead and then HP. That group who had the potential.
Correct. So that's true. So that's why one strategy is doing co-testing. Parallel testing that is why you have to do parallel testing. That is a different strategy. We are coming to that. The idea of what Mohan is saying is that what about these 800? Yeah, then you do both tests.
They had.
Okay, everybody okay with this? Okay, the next strategy is parallel. Okay, tests in parallel. So now what do? PAP on 100,000 followed by HPV on the negatives, right? 93,900. Is that right? You are doing HPV on these 93,900. So this is a modified parallel. You could have done it all together if you wanted. If you wanted just one collection, one swab, one specimen and do both the tests. Or you do it at separate times, you can do it just on 93,900. Then again using the same sensitivity specificity that we have, we pick up, out of the 800 we are picking up 720. This is what you are asking. False positives are 9,310. If you do HPV first on 100,000 followed by PAP on 88,400, then out of the 200 you are picking up only 120 because sensitivity of PAP is 60%. Okay. So now which of all these different strategies, what are we going to choose? So basically when you do parallel testing, you are doing something like this. PAP positive 6,100, HPV positive 11,600. Just to understand what's going on, both positive, it could be 0 or to 100, 6,110. Basically this circle is within this circle or outside the circle theoretically. But when we actually run the numbers, we found that it was somewhere here. Maybe slightly outside. Either positive, it could be range like this or that. Cases picked up anyway is 1920 if you use a parallel strategy. Right? 1920. Because you have to add this 720 and this 120 to the 1080. Okay, so this is so how do we decide which strategy to use? It really depends on the costs of the different strategies and the value that you attach. I mean, on missing a case or the
severity of the disease.
yeah. So, are you feeling very bad if you miss one case, or do you feel bad if you overtreat? So, is it under treatment or no treatment worse than over treatment? So that will depend on the situation, which condition, which treatment, what are the consequences and all that. So, which one?
Sir, why we are taking the 800 as CIM? What is it?
This, see, because here, we know there are 2000 disease because the prevalence is 2%. Now out of these 2000, PAP picked up 1200, remaining is 800, which was false negative on PAP. So when we do the HPV, out of the 800, we'll pick up 720. So 720 plus 1200 is 1920. So if you do both the tests in parallel, you will pick up out of the 2000, 1920. You're missing only 80 cases. So that is why, for a long time we were saying do co-testing, do both tests so that you don't miss any cases. But the Indian government is not, or the Tamil Nadu government is not impressed. Because who's going to pay for it? And so to see what the cost is, I'm just again arbitrary. Pap smear 500 rupees, HPV 2000 rupees, false positive, what is the money on it? Okay, I just put 1000. We can argue about it. Or let's say I just put 1000 because to do a colposcopy is 1000 rupees. False negative, I put 10,000 rupees. But treating a cancer may be 100,000 rupees. Okay, but we are talking of pre-cancer, that's why I didn't want to put 100,000. If you may catch the person after a few years, they've got a long window period. Nothing very much is going to happen if you don't catch the disease today. You can catch it 1 year later, 3 years later, 5 years later. So anyway, I just put this arbitrarily 10,000 rupees. So let's run the math. Who wants to do the math? Okay, this is a simulation exercise. So this is how it goes. I did the math. So different strategies so if you do standalone tests, what is the cost? Cases identified by PAP is 1200, HPV is 1800. False positives here are 4900, here 9800. Test positives are 6100, 11600. Okay. Cost 64 million rupees. 214 million rupees. Okay, just for 100,000 population. Just one block. So there are, I don't know how many districts are there in Tamil Nadu. 30, yeah? Some 30 districts, each with 20-30 blocks or more. So it's a huge amount. So very quickly, so no wonder the policy makers are not listening to the doctors, because doctors have no idea what how much it's going to cost. Let's look at serial or parallel. So we said there were 2000 cases in the 100,000 population. Cases identified by serial testing is 1080. Parallel testing we have picked up 1920. False positives 1570. If you do PAP and then go to HPV, it's 10,030. If you do HPV and go to PAP, it's 4,530. If you look at the cost, if you do PAP and then HPV, it is 73 million. HPV and then PAP, it was about 216 million. And for parallel testing, it's almost 249 million. So, now if you are the policy maker, what are you going to do? So maybe this, 73 million here, 64 million here. So either PAP alone or PAP followed by HPV. You're picking up for an extra 10 million from, you're picking up how many cases? Yeah. Not picking up. You're losing actually. Yeah.
But we are also decreasing the number of patient ways to go for the like false positives were being 10,000.
Yeah.
We are decreasing the false positives.
Right. But for decrease the false positive, you have to spend 10 million, 9 million more. So now you have to decide. Do you want to spend 9 million and decrease the false positives or colposcopies, extra workup you have to do? Or do you want to miss a few cases and spend less? So that's a little more easier decision to make. At least you decide 9 million rupees or for, and what you get for that. So that's how you have to, costing and cost benefit analysis or cost effectiveness analysis, we cannot run away from it. But the world over, unfortunately, everybody is saying primary HPV screening. Okay, the cost, they have left out, they were talking about co-testing. Now, even America, they are saying primary HPV screening, you don't get that much benefit if you do both PAP and HPV. HPV alone is enough, is what they now say in US. In India, what is happening? They are still saying, we'll just look at the cervix. Visual inspection is all that we can afford. Even pap smear, we don't have the infrastructure for cytology, we don't have the, money for that. So probably the government, Tamil Nadu government wants to spend only 1 million or 10 million, not even 60 million. Okay, so that's where we are. Okay, any comments or questions or?